Hey guys, welcome back. We are now into the first part of chapter 22, the respiratory system. So, the respiratory system is our the body system that supplies oxygen for cellular respiration and pretty much disposes of the carbon dioxide, which is a waste product of cellular respiration. It is the respiratory and circulatory system together and showing us how closely coupled these two systems are. Respiration involves four processes. The first one, by way of the respiratory system, you have pulmonary ventilation. And pulmonary ventilation is the breathing, the movement of air into and out of the lungs. Then you have external respiration. This is where the air that you breathe in with the oxygen in it exchanges the oxygen and carbon dioxide between the lungs and the blood. Then in the circulatory part, you're going to transport this. So you have the transport of oxygen and carbon dioxide in the blood. And the last of the four processes will be internal respiration. This is where oxygen and carbon dioxide will be exchanged between the systemic blood vessels and the tissues. And right here, it gives you the four processes that I mentioned. It gives it to you by way also with the help of the diagrams that are um, doing it. The pulmonary ventilation is actually a process that's happening right here in the lungs. So it's actually the breathing part. Then you have your external respiration, which is the exchange of carbon dioxide and oxygen between the lungs and the blood. Then the third one is the transport of the respiratory gases, which is um, um, a function where you will need the help of the circulatory system. And then the last one is the internal respiration, which is the exchange of gases between the capillaries and the tissues. And these are all part of or processes of respiration. And so, with regards to the functional anatomy, you have the major organs that would comprise the two major parts of the respiratory system, the upper respiratory and the lower respiratory. The upper respiratory parts will be made up with your nose, the nasal cavity, the paranasal sinuses, the pharynx. And according to your book, the lower respiratory starts with the larynx, the trachea, the bronchi, and the branches, the lungs, and the alveoli. I have to mention what I have in my mind. In essence, there are times when a professor would disagree with the semantics of the textbook. I learned from the get go that the larynx is actually a part of the upper respiratory system, but is actually included in the lower respiratory system in your e-textbook. My opinion is the larynx acts as a critical interface between the environment and the lower respiratory system, making its inclusion in the upper respiratory tract anatomically and functionally logical. But this is open for discussion if you can have a better reason or opinion, or if you can research it and let us know why we should put the larynx in the lower respiratory system. So here again is your cheat sheet, and you can actually use this when reviewing for your exam. And this is another cheat sheet, but your larynx is there, and I disagree with it, but it's up to you to pretty much let me know if I am wrong. You will never see, I don't know, I may be wrong, you will never see a diagram of the respiratory systems showing the larynx to be part of the lower respiratory system. The larynx is always part of the upper respiratory system. So if you can find a picture showing that the larynx is part of the lower, then we can actually like look through and read through that particular textbook and find out why it was actually placed in the lower respiratory system. So let's take a look at the nose and the paranasal sinuses. The nose is the only external portion of the respiratory system, and your nose provides an airway for respiration. But the most important function of the nose, which usually comes up in tests, in exams, is the second one. It moistens and warms the air entering your respiratory tract. It also filters and cleans inspired air. It serves as a resonating chamber for speech, and it houses olfactory receptors. And the nose is divided into two regions, the external nose and the nasal cavity. And here you could see part of the nose where the skin has been removed, and you could see the bones and the cartilages that make up the shape of the nose. Right here you have a mid-sagittal section of the head. One on the left is actually a diagram, it's a drawing, and one on the right is actually a mid-sagittal section of a cadaver head. Let's take a look at the parts of the mid-sagittal head. So you can see the parts here of the paranasal sinuses. First, let's take a look at the nasal cavity. This entire thing here is your nasal cavity. It is found within and posterior to the external nose. It is divided by the midline nasal septum and posterior nasal apertures, which you call the conchae. Okay, these are your conchae. You have one, two, three. These are the nasal conchae. This is where the nasal cavity, at the end of this, the nasal cavity turns into the nasopharynx. The roof is formed by the ethmoid bone. So you could see that your ethmoid bone is right there. And the sphenoid. So pretty much the sphenoid this is sphenoidal sinus. The sphenoid bone is very hard to see. The only thing you could see is the sinuses, but it's there. And then you have the floor of the paranasal sinuses to be formed by the hard palate. This is the hard palate or the roof of your mouth. So the nasal cavity itself is made up of seromucous nasal glands. It is actually mucus secreting mucous cells and serous cells. Serous cells secrete watery fluid containing enzymes. The mucus and serous secretion also contain lysozyme and defensins. You will look at these mucus secreting and serous secreting cells in the lab, and you will have to make sure you know the difference between a mucus and serous cell. Now, the paranasal sinuses have ciliated cells. It is loaded with ciliated cells. They sweep contaminated mucus and posteriorly sweep it towards the throat. The inspired air will circulate inside your paranasal sinuses as it is being warmed by the plexuses of the capillary and the veins in the nasal cavity. The nasal mucosa contain many sensory nerve endings that can cause sneezing to force particles out of the cavity. The nasal conchae, those are the three, superior, middle, and nasal conchae. These are scroll-like mucosa-covered projections that protrude medially from each lateral wall of the nasal cavity. And you have the three sections that I mentioned: the superior, the middle, and the inferior nasal conchae. The nasal meatus or meatus are the grooves that are inferior to each of the conchae. You have the superior nasal meatus, the middle nasal meatus, and the inferior nasal meatus. The shape of the conchae help to increase mucosal area and enhance air turbulence. And pretty much this conchae, during inhalation, conchae and the nasal mucosa will filter, it will warm up, and it will moisten the air that you're actually breathing. And during exhalation, these structures will reclaim heat and moisture. So the paranasal sinuses form a ring around the nasal cavity. You do not really see it as like a ring, but it's actually shaped like that. It is located in the frontal, and in the frontal and the sphenoid and the ethmoid areas, part of the maxillary bones. The function of this the function of these sinuses will be to warm and moisten the air. The paranasal sinuses are a group of air-filled cavities located in the bones of the skull and the face surrounding the nasal cavity. These are your maxillary sinuses that's located in the cheekbones below the eyes. The frontal sinus is located in the forehead above the eyes. You have the ethmoid sinuses located in the bone between the eyes. The sphenoid sinuses located in the bone behind the eyes. Now all of these sinuses altogether will help humidify and warm the air. The sinuses will produce mucus, which helps to moisten and warm the air we breathe. They also lighten the weight of the skull. These air-filled cavities reduce the overall weight of the skull. They also enhance the resonance of the voice. The sinus act as resonating chambers. They contribute to the sound of our voice, and they protect the nasal cavity. They provide a buffer zone between the nasal cavity and the surrounding bones, and protecting it from impact. Let's take a look at some homeostatic imbalance. You have rhinitis. Rhinitis is a general term for inflammation of the nasal lining, resulting in symptoms like runny nose, stuffy nose, sneezing, and coughing. It is really a symptom and not a specific illness itself. There are forms of rhinitis, which includes infectious rhinitis, which is triggered by viral infections like adenovirus or the common cold. You have also allergic rhinitis, which is really nothing but just hay fever, triggered by allergens like pollen, dust mites, or pet dander. Non-allergic rhinitis, it is caused by irritants such as smoke, perfume, or changes in temperature. And other types of rhinitis that induced by drugs or by hormonal changes, or even like atrophic rhinitis. When the nasal mucosa gets to be inflamed, this will actually be uh, this will trigger what you call rhinitis. It can also spread to tear ducts and paranasal sinuses, causing a blockade of sinus passageway resulting in sinusitis or inflamed sinuses, which can lead to absorption of air producing a vacuum, resulting in sinus headache. The pharynx. The pharynx is a funnel shaped muscular tube that runs from the base of the skull all the way down to the sixth vertebrae. They connect the nasal cavity, the mouth, the larynx, and the esophagus. They are made up of skeletal muscles. And there are three regions to the pharynx. The nasopharynx is right behind the paranasal sinuses or paranasal cavity. Inferior to that, right behind the mouth, will be your oropharynx. It's just behind the uvula. You can see the uvula right there. And then the laryngopharynx is that particular back where you find the larynx. So the nasopharynx is this is your nasopharynx. It's an air passageway that is posterior to the nasal cavity. It lines it is lined by pseudostratified columnar epithelium. It is behind it is actually all the way down to the soft palate, the uvula, and uh, pretty much the uvula, when we are swallowing, will close up. We'll close the nasopharynx during swallowing so that nothing of the food that we are swallowing will go and enter the nasal cavities. The pharyngeal tonsils. The pharyngeal tonsils are up there. You call that the adenoids, and it's located on the posterior wall of the nasopharynx. Then you have also the auditory tubes. Somewhere here is your auditory tube, which is pretty much like part, well, already part of the pharyngeal. I'm already way down in the pharyngeal. Uh, Pretty much the pharyngeal tonsil is actually there, which is pretty much uh, no, the pharyngeal tonsil is up here. Yeah, up here. And it's located on the posterior wall. The pharyngeotympanic tubes or the auditory tubes would drain and equalize the pressure in the middle ear. It's not really, drawing is not good, but it is actually somewhere here. And it helps in equalizing pressure in the middle ear. The oropharynx is behind the oral cavity. It serves as a passageway for food and air uh, to travel down into the esophagus. Um, the lining of the oropharynx is stratified squamous. Uh, the isthmus or the opening is actually isthmus is actually the opening to the oral cavity, and your palatine tonsil, although it's not really quite visible here, is right there by the oropharynx. And then the lingual tonsil is located on the posterior surface of the tongue. That one I could see. And finally, you have your laryngopharynx. This is your laryngopharynx. It is the passageway for both food and air, and pretty much is posterior to the upright epiglottis. That is your epiglottis. Extends down to the larynx where it is continuous with the esophagus. It is lined with stratified squamous epithelium. Now, the thing here is that you can dangerously swallow food, and pretty much like the food can actually go into the windpipe. But that's going to be prevented by reflex. This epiglottis will fold down, closing the opening to the larynx or the windpipe. So your food goes straight all the way back down into the esophagus. Take note of this particular model because these models of the respiratory system will be in your lab exam. You will have to make sure that you know the parts of this model all the way up from the larynx. You have your dissectable larynx and you have the lungs to be dissectable also. It'll be good, just like I mentioned, if you can go to directed study to touch and see and identify the parts of this. Although if you can't, you have your lab and you have your your tutors in the lab by which I have already explained to you in your orientation that you will need to avail of so you can actually study in the lab better. The larynx. Let's take a look at the anatomy of the larynx. It extends from the third to the sixth cervical vertebrae. Just like what I said, I know the larynx to be part of the upper respiratory tract, but your textbook um, has claimed to has claimed to put it in the lower respiratory tract. So, for purposes of us just following the textbook, okay, you can. I will accept your answers if you say that the larynx in a question when I ask you if the larynx is actually part of the upper or the lower respiratory tract. If you say it's lower, then I will understand why you said it. So the larynx is made up of nine nine cartilages. You call it the voice box. It opens into the laryngopharynx and is continuous with the trachea. Matter of fact, you can see the tracheal cartilages already here. And it provides a patent airway, routes the air and the food into their proper channels. And it houses the vocal cords. So it is responsible for voice production. And you can see the larynx externally, most especially among men, because men has what you call the Adam's apple. The Adam's apple is really nothing but the laryngeal prominence. This is the thyroid cartilage of the larynx, and it is very prominent among the males because they secrete a hormone because of their hormone testosterone. Testosterone pretty much stimulates the growth of their laryngeal prominence. That's why it becomes very prominent. The growth of that hyaline cartilage is very responsive to the level of testosterone of the man. So the framework of the larynx consists of nine hyaline cartilage except for the epiglottis. The epiglottis is actually made up of uh, elastic um, cartilage. Uh, these cartilages are connected by membranes and ligaments. The first is actually your thyroid cartilage. And the thyroid cartilage is this one here. And the thyroid cartilage resembles an upright open book or a spine of the book, pretty much. It's the laryngeal prominence or the Adam's apple. Then you have the cricoid. The cricoid, this one here is a cricoid cartilage. Again, it's been cut off, but the shape is pretty much looking like this. But the thyroid cartilage is actually the one that's missing. It has another big flap here, and they had to remove it so it could show the rest of the internal structures of your larynx. But the cricoid cartilage is ring. So this is a closed ring. And pretty much it is only one. So you have one thyroid cartilage, which is hyaline cartilage. You have one epiglottis, which is elastic cartilage. You have one cricoid cartilage, which is hyaline also. Everything else is hyaline except for the epiglottis, which is elastic cartilage. Then you have a paired of erythenoid or arytenoid cartilage. This thing here that looks like a tiny snake there with a head. The body of the snake is actually your arytenoid cartilage. Then you have your cuneiform. This is actually another snake hiding there. The cuneiform cartilage, you have a pair of cuneiform cartilage, one on each side, and the third one is uh, corniculate. That little tiny thing, the head of the snake, is your corniculate cartilage. You have a pair of that too. And let me take a look at and let me say something about the epiglottis. It's the only one that has the elastic cartilage, not hyaline. It covers the laryngeal inlet. This is actually the inlet of to the voice box for, during swallowing. It is also covered in taste buds. So pretty much when you burp and you just ate the buffalo chicken and then you burp your buffalo chicken because you've eaten so much of it and it is so hot and your Esophagus is right around here, and if you burp something there, you will feel right there on your throat, right there by your voice box. As a matter of fact, at that point in time, when you feel that hot, spicy or hot spice of the buffalo chicken, it's going to burn the entire opening of your uh, larynx, and it hurts. So you know that it can actually taste. It can taste most especially the spices. Then you have the vocal ligaments. They form the core of the vocal folds or the true vocal cords. The ligaments lie deep into the laryngeal mucosa. You could see it here. They have removed the thyroid cartilage, and therefore you could see part of the vestibular fold, which is a false vocal cord. But the vocal fold is actually the lower fold right there, and they contain elastic fibers that appear white because of lack of blood vessels. So this one here, even in your models, would appear that it is actually white. The glottis is actually that opening right there, the opening through and through, right through where your air would pass through, the opening between two folds. Not that, that's not an opening. The opening is right here, right through, is actually called the glottis. The folds will vibrate to produce sound as the air rushes up from the lungs. And you have here a good picture of the larynx, the vocal cords of the larynx. You have the two vocal folds. These are the two vocal folds, and the glottis is that opening right there. Here the glottis is open, and here the glottis is closed. Okay, so the folds actually open and close, and they can open slightly or open very wide, and that will change the pitch of the voice. That helps in modulating the voice. Speech is the intermittent release of expired air during opening and closing of the glottis. Pitch is determined by the length and the tension of the cords. The loudness depends upon the force of air. The chambers of the pharynx and oral, nasal, and nice and sinus cavities amplify and enhance sound quality. Sound is shaped into language by muscles of the pharynx, the tongue, the soft palate, and the lips. So, what are some clinical manifestation or homeostasis of the larynx? Well, you can have laryngitis, which is the most common. It's inflammation of the vocal folds that causes the vocal folds to swell, interfering with vibrations, and results in changes to vocal tone. It causes hoarseness of the voice, and in severe cases, uh, loss of voice or loss of speech. Laryngitis is most often caused by viral infection, but may also be due to overuse of the voice, and very dry air, bacterial infection, and tumors on the vocal folds or inhalation of irritating chemicals can cause laryngitis. There you go. And we go down to in that we go down over getting close to the lungs, but we're not just in the lungs, we're into the windpipe. Windpipe extends from the larynx into the mediastinum, where it divides into two major bronchi. It is about 4 inches long and 3/4 of an inch in diameter, and it's very flexible. The carina, that there, where I have my pointer, is the last tracheal cartilage that is expanded and found at the point where the trachea branches into two main or two primary bronchi. The mucosa of the carina is highly sensitive, and whenever it gets irritated, if something lands there, you are going to violently cough. And will be triggered by any foreign object that you actually uh, can actually irritate it. Those people who would pretty much like first encounter a smoke, okay, all right, like a person who is trying out how it feels to be smoking would violently be coughing because that little smoke has actually irritated the carina. So the trachea is made up of, well, the walls of the trachea is made up of three layers. You have the mucosa, which is made up of, that's the mucosa right there, made up of pseudo-stratified epithelium. It's actually ciliated pseudo-stratified epithelium with goblet cells. So they produce mucus. The goblet cells are the ones that are producing mucus. The submucosa behind the epithelium or under the epithelium is a connective tissue with seromucous glands supported by about 16 to 20 C-shaped cartilages. This is your C-shaped cartilage. Your blue line there is the C-shaped cartilage. And it is, the reason why it's blue is because it is made up of hyaline cartilage. And then adventitia. The adventitia is the outermost layer made up of connective tissue. And here, which is also going to be in your lab, you should watch out for the tracheal histology or the histology of the trachea. And this is exactly how the trachea would look like. It is lined with pseudostratified epithelium. You could see the cilia. This is really a beautiful histological picture. You have the uh, submucosa, and then you have your hyaline cartilage, and those cells there are the chondrocytes of your hyaline cartilage, and they are actually sitting inside the lacuna, if you remember that in your hyaline cartilage in your AMP1. So let's take a look at some of the clinical difficulties in the lining of the trachea. Well, smoking, I just mentioned smoking. Smoking inhibits and ultimately will be destroying this beautiful cilia. Okay, and you could see here the ciliary layer of a person who is actually smoking. The length of the cilia is not as long as the length of the cilia of a normal non-smoker. And without this ciliary activity, coughing is the only way to prevent mucus from accumulating in the lungs. However, everything is actually reversible. When a person stops smoking, ciliary function usually will recover within a few weeks. The morning smoker's cough will subside once the ciliary function is restored. So the reason why you have your morning cough, if you are a smoker, is because you have practically like cut down the length of your cilia in half, or sometimes you have debrided your mucous membrane of the cilia. And the only way really to get rid of particulates will be to cough it out. So here's another one, another homeostatic imbalance, which is what we call tracheal obstruction. It is a narrowing of the trachea and can be serious and potentially life-threatening condition. It can be caused by a variety of factors, including tumors, infection, external compression, and symptoms can vary from mild cough or even wheezing to severe respiratory distress, even respiratory arrest. And the cause of this tracheal obstruction is could be a tumor, a foreign body, maybe inflammation brought about by infection or allergic reaction or even trauma. If the obstruction is due to lodging of food or particles it can usually be expelled using an emergency maneuver, which you call the Heimlich maneuver. And this procedure uses the air in the victim's lungs to pop out or expel the obstructing piece of food. The maneuver is really simple to learn and easy to do, but is best learned by demonstration because when it is done incorrectly, it may lead to cracked ribs. Let's take a look at again more of the physiology in the lower respiratory system. The air passages in the lower respiratory tract undergoes 23 orders of branching. This branching is actually referred to as the bronchial tree. The lower respiratory system consists of the larynx, the trachea, the bronchi, the lungs, and is broken into zones. You have the respiratory zone, which is uh, that particular part of the tube where you have gas exchange. And this is actually continuous or is actually an extension from the upper zone, which is the conducting zone. So you have the respiratory zone, and it's made up of microscopic structures such as the respiratory bronchioles, the alveolar ducts, and the alveolar. And then you have the conducting zone, the conduits that transport gas to and from the exchange site and includes all other respiratory structures that is superior to the respiratory zone. These they will cleanse, they will warm, and they will humidify the, the air. So air will flow from your nasal and oral cavities all the way down, going down to the larynx, and then into the trachea, and then into the bronchi, and that's actually your bronchi, your two primary bronchi, and then you will have the bronchioles. And these are still conducting zones until they reach, particularly around this area where you have the alveoli, it becomes the respiratory zones. The alveoli primus are the only place where significant gas exchange will take place. But there's actually also the respiratory bronchiole that would already allow gas exchange. So So this is actually your conducting zone from the entire trachea, bronchi, the primary bronchi, the secondary bronchi, wherever you can see it, that is still part of the conducting zone. And the respiratory zone is already part of the things that you cannot see because they're microscopic. However, I think we do have a picture of that. Okay, here is an enlarged portion coming from the terminal bronchiole. The terminal bronchiole, which is the end of the conducting zone, this is not respiratory. Gas exchange will not happen in the terminal bronchiole. Gas exchange will start to occur right there in the respiratory bronchiole. So from the respiratory bronchiole into the alveolar ducts, into the alveolar sacs, gas exchange can actually occur. And that's why this area here, okay, you have it here, is what you call the respiratory zone. You have to make sure that you know histologically how to identify these different structures histologically right there. Here you can see the respiratory bronchiole. So this particular area here is respiratory bronchiole. So it is already part of the respiratory zone. And over here, this will be your alveolar sacs. And over here, you see like something like an empty space, but it's an elongated empty space. That will be your alveolar duct. And those things that are made up of Truly, when you look at this under the high power objective, this is going to be like made up of simple squamous epithelium. That will be your alveolar sac. So let's view the alveolar sac up close with its accompanying capillary. So we can see another structure, another popular structure, which we call the respiratory membrane. So this is your um, alveolar sac together with its accompanying blood vessel. This is where gas exchange is actually happening. Gas from the air that you're breathing will now get into your circulatory system to be delivered to the different parts of the body. And voila, this is now your alveolar sac, and it will show you the respiratory membrane. By definition, the respiratory membrane is the blood-air barrier that consists of alveolar and capillary walls. So these are your alveolar walls. There you go. But your capillary is not always around. Here's one area where you have a capillary. There's another capillary. Yes, you are capillary. But these sections here do not have capillary, and therefore, where you do not have any capillary, that is not part of the respiratory membrane. The respiratory membrane is only that intersection of the alveolar sac with the capillary. And an enlarged version is this part here. You have a capillary, you have the alveolar sac, and this membrane here, the intersection, is where gas exchange is happening. An exchange of gas between the circulatory system, between the capillary and the alveolar sacs, where your oxygen can now enter as you breathe in fresh air, and carbon dioxide from the blood will be released as your blood flows into your alveolar sacs. And what happens here, guys? How do they do that, guys? There's no magic here. This is really nothing but just plain diffusion because of concentration gradient. If carbon dioxide, the incoming blood, carries more carbon dioxide will flow out and will fill the alveolar sacs. If the incoming air that you're breathing in is actually loaded with oxygen, then the oxygen will flow from an area where it's greatly concentrated to an area where it is less concentrated, which is the blood. So there's no magic here. There's no active transport. There's only diffusion of gas according to concentration gradient. So now you have the lungs. The lungs occupy all of the thoracic cavity except for the mediastinum. This is your lungs, and that's your mediastinum. You have an empty space there because the heart was removed. So you could see that space there. That is supposed to be the space for the heart. Now, the root of the lungs is a site of vascular and bronchial attachment to the mediastinum. The costal surface, pretty much the costal surface is the anterior, lateral, and posterior surfaces. The apex, the superior tip, that is actually deep to the clavicle, and the base is actually the inferior surface that rests on the diaphragm. This is actually the section of the mediastinum. If you're going to recall my uh, my explanation on how the heart is actually positioned, that's actually I just mentioned to you how the heart is actually positioned inside the mediastinum. Again, the apex of the heart is actually deep into the uh, right there. It is actually pointing up there. So the apex of the heart is actually causing that cardiac notch. We call this a cardiac notch. And the base of the heart is resting right here on the diaphragm. The hilum of the lungs is found on the mediastinal surface. And this is actually the hilum of the lungs. And you got two of them because you have two lungs right there showing you. It is the site for entry and exit of blood vessels, bronchi, the lymphatic vessels, and the nerves. The left lung is separated into superior and inferior lobes. You have the left lung right here, superior lobe, inferior lobe, and is separated by an oblique fissure. So your fissure right there is oblique. The left lung is slightly smaller than the right because of the position of the heart. A cardiac notch is a concavity that is formed because of the heart, because that's where the heart actually goes. The right lung is slightly bigger, and the right lung is separated into superior, middle, and inferior lobes, which are separated by fissures. The superior and middle is separated by a horizontal fissure, and your middle and inferior, you see the middle and the inferior is separated by an oblique fissure. And you could see here the general view of the lungs that is actually on a person. Not so bad. And also the transverse section of the body showing you the lungs and its relationship with the heart. You could see the mediastinum and you could see the heart. This is actually a cross section of a transverse section of the body or through the chest area or the thoracic area. So, pretty much your lungs is actually divided into bronchopulmonary segments. Each lobe is further divided into bronchopulmonary segments, 10 on the right lung and about 8 to 10 on the left. They are separated by connective tissue, septa, and each segment is served by its own artery, own vein, and bronchus. And if one segment is diseased, it can be individually removed from the rest of the lungs. The lobule. You have here a picture of the lobule, the smallest subdivision visible to the naked eye. Okay, it's a hexagonal, usually hexagonal segment, and is served by bronchioles and their branches. The lungs are mostly composed of alveoli, and the rest consist of stroma of elastic connective tissue. So the lungs are perfused by two circulation. The pulmonary circulation is subdivided into pulmonary arteries. They deliver systemic venous blood from the heart to the lungs for oxygenation. These branch profusely to feed into the pulmonary capillary networks. The pulmonary veins carry oxygen-rich blood from the lungs, from the respiratory zones back to the heart. The pulmonary veins' low pressure and high volume system pretty much is the one that allows the exchange to happen. The lung capillary endothelium consists or contains many enzymes that act on different substances in the blood. For instance, you have your angiotensin converting enzyme, which is your ACE. I mentioned that to you that this is the enzyme that converts angiotensin 1 into angiotensin 2. It activates blood pressure hormone angiotensin 2. Now, bronchial circulation starts with the bronchial arteries that provide oxygenated blood to the lung tissue. It arises from the aorta and enters the lungs at the hilum and part of the systemic circulation, so are high pressure and low volume. So pretty much bronchial veins, anastomose also in the lungs with the pulmonary veins. And the pulmonary veins carry most venous blood back to the heart. So the lungs are innervated by the parasympathetic and sympathetic motor fibers. That's the parasympathetic motor fibers and sympathetic and parasympathetic. And as well as visceral fibers. The nerves enter through the pulmonary plexus. And let me see if I can, there you go, that's where the pulmonary plexus is, on the lung root. Parasympathetic fibers cause bronchoconstriction, whereas the sympathetic fibers can cause bronchodilation. The pleura, the pleurae, or the membrane. This is actually a thin, double-layered serous membrane that divides the thoracic cavity into two pleural compartments. One, two pleural compartments, where the right and the left lungs would be housed, and a third compartment, which is the mediastinum, where the heart will actually be sitting. The pleura is double layered serous membrane. Okay, I mentioned that already to you. And it is divided into the visceral pleura and the parietal pleura. The visceral pleura is exactly the one that's directly covering the lungs. The parietal pleura is the one that is covering the parietal wall. The visceral pleura is a membrane on the external lung surface. Between the visceral and the parietal pleura is actually a space that is filled with, it's just a slit-like space that is filled with fluid. You call this slit-like space the pleural cavity. It provides lubrication and surface tension that exists in the expansion and recoil of the lungs. And the reason why we are able to carry our lungs without our lungs collapsing is because of the negative pressure that is inside that miniature space. The intrapleural pressure is actually a negative pressure. Pleurisy is inflammation of the pleura and is often resulting from pneumonia. An inflamed pleura becomes very rough, resulting to friction and stabbing pain with each breath. The pleura may produce excessive amounts of fluid, which may exert pressure on the lungs, which hinders breathing or normal breathing. Other fluids that may accumulate in the pleural cavity will be your blood, which is actually probably leaking from damaged vessels, blood filtrate, the watery fluid that oozes from lung capillaries when left-sided heart failure occurs, pleural effusion, this is a fluid accumulation in the pleural cavity. And pretty much, I think this is already the last, and I am going to see you in the next or part 2 of this chapter.